Ladies and gentlemen, dear friends and colleagues of the European Society of Gynecology and of the European Society of Contraception and Reproductive Health, welcome to this joint webinar. Today we will speak about what is new in intrauterine and emergency contraception, and I would like, as President of the European Society of Gynecology, to thank the European Society of Contraception and Reproductive Health for that fantastic opportunity to have a joint meeting together. We will have two fantastic speakers, Professor David Serfaty and Professor Ali Kubba. I will introduce now Professor Serfaty, and then before his talk, I will introduce Professor Kubba. Professor Serfaty is a French gynecologist, founder, and currently honorary president of the European Society of Contraception. He is the past president of the European Society of Gynecology. Then you can see the fantastic linkage that we have. And currently is president of the Francophone Society of Contraception and the International Consortium on Male Contraception. He's author of 7 books in contraception, and the 8th is in progress. David, you have the microphone for your talk on intrauterine contraception, new and future concepts. Please, if you can.
Thank you very much, Mr. Chairman and dear friend. I am particularly happy to take part in this webinar because the two societies, as you know, are very important in my life. So, as you know, according to the United Nations, 17% of women of reproductive age use IUD worldwide. And we can see that globally, the prevalence of the pill, the IUD rhythm methods and withdrawal has remained relatively stable over the past 25 years. It's not the same, it's not the case of all countries. For instance, in France, IUD is the first contraceptive reversible method after the age of 30-45. Only to know. I begin by the first concept. The first concept is enhancement of existing IUDs. Exactly, it's enhancement of the bleeding profile of existing IUDs. How to do that? We have to alter the delivery profile for Cooper by lowering the doses of Cooper ions from the IUD without decreasing efficacy. How to do that is to put Cooper in the strategic area. It means ostia, tubal ostia, and cervix. Like this, we will obtain the Veracept low-dose Cooper, currently in clinical trials. This is an example of this approach to lower the dose of Cooper. The second principle is to integrate Cooper nanoparticles in the device to decrease the burst of Cooper release. Like this, we can obtain the Cooper low-density polyethylene nanocomposite intrauterine device. This is the nano Cooper IUD, is a Chinese one. It's not, this IUD is not available in Europe, but it is available in China. And another approach is to add an additional active pharmacologic ingredient with the goal of improving the bleeding profile, either in terms of volume or frequency. We obtain the endometacin releasing Cooper intrauterine device. This is the endometacin gamma Cooper, very successful also in China. Another approach is to include a progesterone receptor modulator in a small reservoir to prevent bleeding associated with Cooper IUDs. Like this, we can obtain the ulipristate acetate Cooper IUD. This is the Cooper intrauterine system releasing ulipristal acetate. You can see the small reservoir. And now, according very recent randomized proof of concept study, very recently published, according to this study, we can conclude that by preventing Cooper-induced increase in bleeding, this IUD could provide a non-contraceptive benefit, especially for women with low hemoglobin. The effect of decrease of the bleeding is proportional to the dose of UPA released, but also the frequency of PRM-associated endometrial changes, in theory benign, are also proportional to the dose of UPA released. Another system is to use new material, such as nitinol. Nitinol is a alloy of nickel and titanium, where shape memory and elasticity properties offer a theoretical advantage in terms of retention, ease of insertion, or comfort over the existing models, especially among sexually active youth, especially, but not only in sexually active youth. This is the nitinol Cooper IUD, the Veracept IUD. Another example is the intrauterine ballerine in France, where the classic T shape is replaced by a series of Cooper pearl, is no more available in France. What about the levonorgestrel intrauterine system for tomorrow? Currently, we have Mirena, Jaides, Kailina, and we have also a hybrid of Mirena, Donacert. So it means that we have four intrauterine system, levonorgestrel intrauterine system. Tomorrow, perhaps we will have the combi intrauterine system. It means we combine levonorgestrel with anti-inflammatory drug, such as endomethacin. Perhaps we will have, perhaps, I'm not sure, we will have the Kailina combi. Finally, the last new IUD I speak about today is the Levocept intrauterine system with small reservoir release levonorgestrel is in clinical trial now. The second part of my talk is to speak really on a new and future concept. The first one is the same-day IUD access. The concept of the same day, by definition, is a concept concerning the insertion of large and more particularly IUDs. It consists to insert the IUD during the first medical appointment for contraception. The screening of sexually transmitted disease, if indicated or necessary, will be done on the same day, followed directly by the insertion. If an infection is detected, the patient will receive a treatment while the IUD is in place. According to Wilkinson, his last publication, this is his conclusion, interesting one. Our findings highlight the high rates of pregnancy, 28%, when adolescent and young adult women are required to make 2 visits to have an IUD. And finally, efforts to provide same-day access for all contraceptive methods are needed. I would like also cite the leader in contraception, Robert Hatcher. He said, everything we have learned about the delivery of contraceptive services suggests they should be available to every woman who want it on the first visit after they have been told all the contraceptive options. The second concept is the immediate postpartum intrauterine contraception. We can say that the immediate postpartum intrauterine devices are safe and effective, but largely unavailable in Europe. Yet, this immediate postpartum IUD in maternity services can help address unmet need for effective contraception in the immediate postpartum period and also after. According to Bronson and Jackson, the importance of providing women with immediate postpartum contraception, including LARC, is supported by evidence that demonstrates it can reduce the incidence of short inter-pregnancy intervals and unintended pregnancy and abortion. Very recently, a specially designed inserter aims to facilitate IUD insertion within 10 minutes to 48 hours after delivery during the postpartum period. This is this inserter. As you can see, has very long inserter and very long string, and it exists one slight in sleeve to ensure string and stabilize IUD in correct plan for insertion. Perhaps thanks to this insertion, this system would be used more frequently. And if you use this inserter, we can avoid to put hand in the vagina. Like this, we can avoid contamination. But we have question. After Rivas, I ask, are Wisconsin resident physicians trained in immediate postpartum IUD insertion? We can have the same question in all parts of the world. Are we trained in immediate postpartum IUD insertion? Question. The third concept is IUD self-removal. While Familial Planning Association and gynecologists in general do not recommend the self-removal of IUDs, online information exists on how to remove an IUD on self. And finally, an unknown proportion of IUD users remove their own IUD. According to Foster, half of patients presenting for IUD removal were interested with attempting self-removal, and that 20% of these patients were able to remove their IUD with instructions from their providers. Some women do not choose the IUDs because they cannot stop this contraception by themselves. A better understanding of the self-removal of IUDs could help to encourage women to choose this method of contraception when they want to stop this contraceptive method by themselves. One word about the COVID pandemic. This pandemic affected several aspects of women's life, in particular non-urgent medical visits. But the medical structures, which are only dedicated to emergency care, are not adapted to propose medical appointments for the removal of an IUD. So the self-removal can be used particularly during pandemic, not only pandemic, also in wartime, for instance, in certain countries, or outside these two circumstances. Now, not last, but almost the last concept, what is new in emergency contraception? Reply is levonorgestrel IUD as emergency contraception. As my colleague and friend Ali Kubba will speak on emergency contraception, I come back on the conclusion of very recent randomized multicentric study from University of Utah. The conclusion is that the IUD levonorgestrel is not inferior to the IUD Cooper for emergency contraception. And this IUD is efficient whatever the date of the cycle. Now, the Food and Drug Administration must approve the IUD Cooper and the IUD levonorgestrel in emergency contraception. If we can have this approval, if we add IUD Cooper plus IUD levonorgestrel in emergency contraception, perhaps we can decrease the number of abortions. And the last concept, new concept, is this one: intrauterine contraception or female sterilization by laparoscopic tubal ligation. To reply to this question, let's have a look on this very recent trial, the contraceptive effectiveness and safety of intrauterine contraception and the tubal ligation by Schwartz. It's a retrospective study, and the key results are the following. More than 35,000 patients who had levonorgestrel intrauterine device placed, 23,000 patients had Kubba intrauterine device placed, and 23,000 patients underwent laparoscopic tubal ligation. Result: intrauterine contraception appears at least as effective as laparoscopic tubal ligation at 1 year post-procedure, with lower rates of infection and pelvic pain 6 to 12 months post-procedure. It's time for me to close and to say thank to some pioneers of the intrauterine device. The first one is Jaime Zipper from Chile, who discovered the anti-nidation effect of intrauterine metals ions, including Kubba. And after him, we have Howard Tatum, he's American, he's from the United States, who has combined tubular with filamentous Kubba. He is the father of the currently the gold standard IUD instead. And finally, the Finlandi Tapani Lukainen, the father of the famous levonorgestrel intrauterine system Mirena. And thank you very much for your attention.
Thank you very much, Professor Serfaty. We will have the discussion about your data on intrauterine contraception after the presentation of Professor Ali Kubba. Professor Ali Kubba is senior consultant gynecologist in the colposcopy unit and in the sexual and reproductive health care at Geese and St. Thomas Hospital in London. He is the honorary senior lecturer at the King's College, Department of OBGYN in London, and is consultant at the London Bridge Hospital in London and Harley Street. He's the honorary professor at Basra School of Medicine in Iraq, and is the past president of the International Affairs Committee of the United Kingdom Faculty of Sexual and Reproductive Health Care. But is also current vice president of the European Society of Contraception and Reproductive Health and advisory board member of the European Society of Gynecology. And today we are delighted to hear you about emergency contraception revisited. Ali, you have the microphone.
Thank you. Thank you very much, Professor Janazani. And can you see my slides and hear my voice?
Perfect.
Yes, very good. And I'm really delighted to be taking part in this joint meeting with of the European Society of Gynecology and European Society of Contraception and Reproductive Health, and really to share this platform. It's my honor to share the platform with two giants in gynecology and contraception, Professor Janazani and Professor Serfaty. This is my email in case anybody wants to email me. And I'm going to talk about emergency contraception. I may miss some slides because we want to have time for questions. And the two images here give you the indications for emergency contraception, either non-use of methods or a failure of a method, usually a condom. So an overview of my presentation, I'm going to look in a very general way about safety, efficacy, and mechanism of action, all of which are backed by very robust evidence. And this is very important because people doubt whether emergency contraception is safe across the reproductive age range, about whether it works, about the way it works. There are challenges, there are misunderstandings, and there are politics associated with emergency contraception. The view that it encourages irresponsible sexual activity is wrong. There is no increase in sexually transmitted infections in women who access emergency contraception, and there is no evidence that it stops women from using a more regular and more effective method of contraception. There is a challenge in access to information and access to all the methods, especially the copper emergency IUD. I think there is also a cultural and societal challenge, accepting that sex just happens, accepting that contraception can fail, and accepting that no one is perfect. So we should not be judgmental when we deal with a consultation on emergency contraception. I'm going to talk about some of the new concepts, developments, the hormonal IUD, weight and the effect on efficacy, and repeat use, frequent use, and the pericoital use. So this is to really make the point that there has always been a need for postcoital methods. And it is said that postcoital conception was probably the first method of contraception used in ancient times. But I wanted to just show you this slide. This is the self-acting douche of Monsieur Weiss. And it was introduced as a postcoital exercise. So you put whatever you think is spermicidal into this. The woman sits on this douche. It's like a bidet. So some people say that the introduction of bidets in Europe is probably a postcoital or emergency conception idea. And then you put this in the vagina and then you squirt the contraceptive. But this is a study that was published in the faculty journal, BMA SRH, this time last year, looking at a survey of Paris medical residents. So these are doctors in Paris in 2020. 409 were surveyed, 2/3 were female, and emergency conception use was 17.5% in the females, and very, very encouraging, 7.6% of the male doctors also said that they went and obtained emergency conception for their girlfriends or for their wives. So in the modern times, in people who are very well informed about contraception, you still have a need. So we need to simply accept that. And if we look at Europe, emergency conception is widely used. This is a compilation of surveys that have been done at different times between 2010 and 2014, and it shows the use in different countries. The UK has a pretty high use because the method was actually introduced in the 1970s and early 80s, and therefore awareness of it is quite high. I wanted to show you 3 countries and see how the use of emergency conception has increased. So we start with Spain, and you can see that this survey of women between 15 and 49 shows an increase from 14% in 2011 to 38% 2020. And 38% is a good figure for you to remember, because that's usually the percentage of the population globally that said at least once they've accessed emergency contraception. If you look at the USA are quite late in coming to emergency conception, though Plan B has been around for a long time, but you can see again the increase. In Italy, this is an interesting study done between 2015 and 2018, looking very much at the specific brands. And you see here the levonorgestrel pill has been increasing, but you can see that from 2017, it started to plateau. Why? Because ELA1, UPA, was introduced and was gaining popularity. And this is indeed something that we need to consider, because the general feeling is that UPA, ulipristal acetate, as an emergency conception is the most effective oral method. The IUD is always the most effective emergency contraceptive. The only country which did not show an increase and actually showed a drop in the use of emergency conception is Norway. And though the slide is long and I don't want to take too much time, but the expert view is that the decline was because there was an increase in the use of regular contraceptives, and especially in the use of long-acting reversible contraceptives. So this is the point about emergency conception, not stopping the population, the sexually active women, from accessing ongoing methods. The second point is about safety. And the slogan which says emergency conception is safer than Coke is very important. The reason why I choose Coke, because Coca-Cola is spermicidal. So in the 60s in the UK, Coca-Cola was used as a vaginal douche post-coitally to try to kill the sperms. So what do we know? We know that the WHO medical eligibility criteria says there are no contraindications to emergency contraception. Saying that, you have to remember that both the levonorgestrel and UPA pills have lactose, and therefore, if women have lactose intolerance or a serious allergy to lactose, you may consider this as a very, very small contraindication. Of course, these patients can use the IUD. The side effects are minimal and transitory. So the message is to say any side effect, whether it's effect on the period, its effect on symptoms such as breast discomfort, these will all clear very quickly, and there is no lasting effect on fertility. Remember, efficacy is time sensitive, so the sooner a patient accesses the pills, the better, the more effective, and therefore we should make oral emergency contraception, hormonal emergency conception, as easy to get as Coca-Cola. Anxieties about the IUDs don't really apply, because if a woman wants to use the IUD just for the cycle to prevent a pregnancy, she can be reassured that the IUD can be removed at the beginning of her next cycle. Remember that unprotected sex increases the risk, has a risk of sexually transmitted infections, and therefore you need to keep that in mind and maybe talk to your patient about that and maybe screen her. And also remember that there is no age restriction. Starting from coitarchy until the menopause, you can use emergency contraception. Now, should we allow emergency conception over the counter? Should we, for this patient who is in cognito in a way, should we open these doors for emergency contraception? Well, the pandemic showed us that there is degradation of contraceptive and pharmacy services, and therefore we want to make it as easy for people to go and get emergency conception from their local supermarket even. We know that if we make the emergency contraceptive a doctor-only process, that is a problem, because many patients would need to pay to see a doctor in a clinic, or there are waiting lists. Some patients love getting emergency conception from pharmacies, but others also talk about lack of privacy, not much time for counseling. And the most important thing is that we need to have information everywhere. They need to be in bars, in clubs. People should be able to know where to go for emergency conception. And making it available over the counter is because we know that there are no contraindications, and because we know it's time sensitive. So the quicker a woman can go buy the method, the pills, the better. Now, some people say, well, what about safeguarding? If you have a 14-year-old who might go to a pharmacy and wants to get the pills, well, the evidence is that in these situations, there isn't really much time to do safeguarding. The important thing is that whoever provides emergency conception needs to be able to signpost the teenager to a service. So as long as there is information to say there is a safeguarding issue and you can refer the patient, that would be probably adequate. And when we talk about over-the-counter, we're talking about no need for consultation, no need for examination, no need for tests. And emergency contraceptive pills are available in that way in Sweden, in the Netherlands, in Norway, and the UK. In other countries, they're available under the counter, meaning that the woman has to go to a pharmacy and have a discussion with the pharmacist. So a consultation is required. The levonorgestrel emergency contraception is available either OTC or under the counter across the world. But UPA availability through pharmacies is high in Western countries, but Poland, Hungary, and the USA are still to put legislation in place to allow its use. And emergency conception is effective. This is the paper that Anna Glazier was involved in, published in The Lancet in 2010. And it shows that overall, the failure rate of hormonal emergency conception is 2%. If you look at ulipristal acetate from this study, you'll see that the failure rate is 0.9 to 1.4. It's higher with levonorgestrel. And levonorgestrel does not really work after 96 hours. The failure rate is much higher. We know, as David just showed us in his slide, that in one non-inferiority study, the failure of the IUS was 0.3%, confirmed with only one pregnancy, while with the copper IUD, there were no pregnancies in that analysis. So time is critical. The sooner, the better, and that is really, really important. And this shows you for levonorgestrel, for instance, that the efficacy, if it is accessed in the first 12 hours, it's much, much, much higher than if you leave it nearer the 72-hour limit. Special considerations on the efficacy. We've made the point that levonorgestrel is not effective after 96 hours. Is not effective after ovulation. UPA may be more effective than levonorgestrel as we approach ovulation. Levonorgestrel is not effective with a high BMI. Some say even a BMI over 26, definitely weight over 80 kilograms. In these cases, consider using a double dose of levonorgestrel. The loss of efficacy with UPA is less in obese women, so this would be the best choice. But UPA is less effective if a progestogen is taken within 5 days of giving the emergency pill, or in the 7 days before starting it, simply because obviously this is a progesterone receptor modulator, and obviously if you have a progestogen in the system, it will interfere with its action. This is a complex slide, but I'm going to summarize it for you. So the idea of what do we do about women who are over the ideal body mass index? Well, we can offer them a copper IUD. That is definitely the best method. But if you have to offer a hormonal contraceptive, then UPA would be the one to choose. If you're going to offer levonorgestrel for whatever reason, then you need to double the dose. That is the conclusion from this. The evidence from this paper, which was published very, very, very recently, was that actually doubling the dose doesn't work. But the point about this is that the Faculty of Sexual Reproductive Health in the UK issued a statement, in a way reviewing this paper, and essentially said there is no evidence that 3 milligrams of levonorgestrel cause any excessive side effects. They're well tolerated, no associated harm, and therefore better than nothing, you double the dose. What about mechanism of action? The mechanism of action is primarily by preventing fertilization, either through preventing ovulation or through interfering with the fertilization, not prevention of implantation. So the emergency contraceptive pill can delay ovulation if taken early enough in the cycle. This is important because it may be that the woman will ovulate later in that cycle, and therefore you must advise her to use an ongoing contraceptive such as a condom. The biological plausibility regarding inhibition of fertilization is through thickening of cervical mucus, and that reduces the number of sperms getting to the upper genital tract, and also changing in the uterine environment, which immobilizes sperms. They actually swim backwards rather than forwards. Endometrial alterations, the evidence is very weak. No clear changes, not clear that the changes observed inhibit implantation. Studies that Craxato did some time ago show no effect after ovulation, and there is therefore no evidence to suggest a post-fertilization effect. So we can say emergency conception stops a pregnancy before it starts. It does not end an existing pregnancy or cause fetal abnormalities. Unipristol acetate, we've talked about, it is the more effective hormonal contraception. Should it be the one to go to? Probably, but it is more expensive. Its cost is an issue. It is definitely good for women with high BMI. It's not for women who are on progestin-containing methods because its efficacy would be affected. It's not for severe asthmatics and those with hepatic impairment. It is not ideal if you have a woman using a liver enzyme inducer, simply because you cannot double the dose. So if you have someone on anti-epileptic medication or antiviral pills, then you use levonorgestrel because you can double the dose of levonorgestrel, but your ideal method again is the IUD. And you can't quick start a contraceptive with UPA. However, we now say you can use UPA more than once in the cycle. If you're going to use contraception in the same cycle, use the same hormonal method you've used the first time. We've talked about liver enzyme inducing drugs. What about postpartum? The risk starts after day 21 with lactational amenorrhea. If the rules apply, then you probably can think about it later. And you can use the levonorgestrel pill, but if you use UPA, the advice is that the mother should express the milk for 7 days. Post-abortion or post-anectopic pregnancy, if you have unprotected sexual intercourse over day 5, then emergency contraception is indicated. If needed in the same cycle, use the same regimen. If they have a levonorgestrel, you give them levonorgestrel again and the other way around. If unprotected sexual intercourse happened outside the fertility period and you want to quick start hormonal contraception, use levonorgestrel rather than UPA, because you can quick start immediately after giving the levonorgestrel hormonal method. What are the rules about missed pills and emergency contraception? If the hormone-free interval is extended over 9 days, if 2 to 7 pills are missed in week 1, remember, 1 missed pill is not an indication, and if more than 7 pills are missed in the 2nd and the 3rd week. And that is important. Missing pills in the 2nd and the 3rd week, the ovary does not recover very, very quickly. And what emergency contraception? We've already talked about levonorgestrel. If you want to restart either the combined pill or progesterone pill immediately, UPA is okay, but you have to delay the restart for 5 days. I've put a slide on transgender patients because they are, in a way, a special need group. A request from a transgender male for emergency contraception will the request needs delicate handling. Pregnancy is associated with gender dysphoria. There is distress and barriers because we see it occasionally when I see patients, because they come and the secretary will come and say there is a man wanting emergency conception because their gender is in the document is male. Consider advanced prescribing, online access, very important. Remember, testosterone is not a contraceptive, even if the person is amenorrheic, and it can impact on the fetus under 14 weeks. And therefore, you need to think about using emergency conception in these cases. Warn about the risk of irregular bleeding. You need to repeat a pregnancy test 2 to 3 weeks later, post giving the pills because of the amenorrhea. And for ongoing contraception, you can use a progesterone-only method that does not oppose the testosterone effect. The IUD is the ideal method. You need to use a high copper content IUD. It works through the copper impacting on sperm functions, technically prevents fertilization. Hormonal IUDs should work through disrupting sperm and ovum transport. And because we have smaller devices with these, they may be more suitable for teenagers. It's effective up to 120 hours from unprotected sex, but it's also effective up to 120 hours from the earliest calculated ovulation date, which means it can cover multiple exposures in the cycle. and it is obviously effective for the rest of the cycle. This is the study that David alluded to, which is the Turok study. Now, Turok did a study which looked at quick starting the IUS after levonorgestrel emergency conception, and there were no pregnancies. So he was, the team was interested in doing a study comparing the IUS with the copper IUD. And this is a non-inferiority RCT. So we definitely need more studies. And it showed the points that we've made, that there was one failure in the IUS, no failures in the 380, which means it is not inferior. But we need further research. Some of the new concepts, so there is work ongoing about the pericoital use of levonorgestrel 24 hours before or 24 hours after unprotected intercourse. The evidence from this study by Festin was that this is moderately effective, and therefore it is a possible option once we get more studies. The other points I wanted to make is that mifepristone is an emergency contraceptive, but it's not licensed for that. We've talked about post-emergency hormonal emergency conception. With levonorgestrel, you can start on the day. With UPA, you wait for 5 days. The faculty in the UK says give emergency conception even if the intercourse happened in the infertile period. So if a woman comes and says, I have a 28-day cycle, I'm on day 20, still give her emergency conception. It does no harm, and we can never be sure of the menstrual history. And the last aid I wanted to show you, and thanks to the European Consortium for Emergency Conception, is the EC wheel, which allows you to look at all the scenarios I've just given you. I think I've just managed to finish on time. So we think that both pills and the IUD are good methods. And I'm very grateful and thankful for you listening to this presentation. Over to you, Professor Janazani.
Thank you very much. I have now some questions, and then we will start with a question related to your talk, as you know that you will leave. And okay, we start with a question from Helen Patterson. In New Zealand, we do not have ulipristal acetate, but we do have mifepristone. Would you support the recommendation to support mifepristone use in people with higher BMI?
I think mifepristone is quite an interesting concept, and of course, it is effective, and therefore, and there is evidence, there is a lot of research evidence of mifepristone. So I think where you want to use a more effective method, mifepristone probably is, and there is no UPA available, mifepristone would probably be a good alternative. You need to just make sure that if it is not licensed for this, that your patient understands that you're using it off license.
Thank you.
If I add one word, in Russia, the emergency contraception with mifepristone is available.
Yeah.
Yes, but not in New Zealand. And then now a question from John Guillebeau. Why cannot one double the dose of ulipristal acetate if a patient is on an enzyme inducer drug, given the lowering of blood levels in the same, therefore, as happens with levonorgestrel? It is solely a licensing issue, not driven by data?
Yeah, it's really great to see that John Guillebeau is attending it. That's a great honor. He was my boss when I was very, very young. He looks much younger than me. But yes, it's a licensing issue. And it's a licensing issue because there is this anxiety about liver function and UPA.
Thank you. And then also now from Marie-Sophie Aubard. The problem that I see from my friends, gynecologists, is that young people do not want to use pill emergency or classical pill for ecological context. What would you recommend to speak on the subject with them? Because, you know, we are afraid by the fact that all these substances go in the water, and then they go on the river, and then they go on the plants and animals. Do you have any?
Well, yes, well, obviously the IUD is an ideal method. And this is a point where we can also say that the IUDs in teenagers are a definite option. And all anxieties about the use of IUDs in young women or in newly Paris women do not really stand up to scrutiny by research. So you can use an IUD. I think the argument is that the dose is so small and so transitory that it is unlikely to have a major environmental impact. And it is, if it prevents a pregnancy, then you are getting massive value for money. So I think this is, we always say, people who like emergency conception, that it is a very, very, very good investment in contraception to try to avoid a pregnancy and maybe put the person on a regular method of contraception.
I think
also, one word, perhaps also the provider, the gynecologist, for instance, hesitate often to put an IUD as emergency contraception.
Yeah,
the point.
Absolutely.
Point.
Same day, David. Same day.
It's my talk, not yours.
And then Mahumu Miyeye is asking, do emergency contraception cause infertility in women? And how many times it is safe for women to use emergency contraception per year?
So that's a very common question. So thank you very much. And I'm assuming the question comes from possibly outside Europe, we think.
Yes.
Anyway, I think in countries I work with the Middle East, and there's always an anxiety. The effect is so transitory that there is absolutely no effect on contraception. If you think about it, we know that most of the failures of emergency conception is because sex happens after they take the pill. So the method only works if you give it in the right time in the cycle and doesn't affect fertility. How many times you use it? There is absolutely no barrier, no contraindication to using it as indicated. You need to talk to the person in any time. The advice is that if someone has sex in the morning and comes to you and says, I need emergency pill, and they have the sex in the afternoon, they're very lucky, very happy people, and they come again, you don't need to repeat the dose within the first 24 hours. You repeat it afterwards. So there is no limit on that either.
But Ali, you have to say one word more. If women repeat too frequently emergency contraception by month or by year, it means that we have to take time to see his regular contraception. Something doesn't work very well. Huh?
Yeah, that is a very important point. The important point is to make sure that the woman understands that repeated use of emergency conception is not as effective as using a regular method. So it is not a substitute to using a regular method.
And then a question from an anonymous, which I think is interesting. Can we use an IUD as emergency contraception in a woman with bad menorrhagia?
Very good question, because and people say, well, this woman has very, very heavy periods, and if we put a copper IUD, it's going to make the periods even heavier. The point I made, which is the IUD covers the risk of pregnancy. So you can say to the woman, listen, don't worry, when you start the first drop of your next menstruation, come to me, I'll remove the IUD. And therefore, that anxiety about heavy menstrual bleeding does not exist.
And now we have possibility to use levonorgestrel IUD in this case, if she wants to continue to use IUD after emergency, you know?
Yeah, I think, David, I mean, I'm based in the UK, and therefore I will give you the view of the Faculty of Sexual Reproductive Health Clinical Effectiveness Unit, because the study that we've both talked about was a non-inferiority study. The faculty essentially says we need more evidence. So we do not, at the moment, promote hormonal IUDs for emergency contraception.
And then now on a combined question for David and for you is done by Marie-Sophie Obar. She has several questions about the possible use of ballerine, which is being recognized again by European Medical Agency, and the possible use also for an emergency contraception. What do you believe, David? And then
I don't use very frequently this IUD. Now in France, it has disappeared. It's no more available because it is too expensive, very expensive. It's not reimbursed by national security. Second point, because women want contraception not very expensive, and the third argument against is the literature concerning this IUD is not sufficiently definitive. We have to work more to recommend this IUD. You know.
So if I can just add,
yeah.
I think for ballerine, the concept of using a device which has a thin inserting diameter, ballerine has the lowest inserting diameter among all intrauterine contraceptives, is a very good one because it allows you to use it in teenagers, introduces the pain. We need to have the evidence. So going back to the hormonal IUDs, obviously, if we can test Kylina or JDES, the smaller devices for emergency contraception, that would give us an option. That was one of my slides, which I skipped, moved very quickly over. So we need to think about the future research being geared towards allowing the use of emergency IUDs in teenagers, in newly parous women, and therefore using a thinner devices.
Yes, then there is a question now also, still from Marie-Sophie Obash. She's very active, and concerning the fact that the women suffer with IUDs. What is your position about hypnosis and virtual medicine? And what do you believe really, David, on the topic about the fact that the woman, she can have the perception of the IUD inserted in her uterus?
If I understand this question, you speak about the self-removal, not?
Yes, yes. Self-removal should be a solution. But what is the percentage of women who suffer by the presence of IUDs? You believe this is a frequent?
Not.
No. And then?
So just to say to Sophie is the IUD, as you know, is one of the most widely used methods in the world because a lot of the women in China use it and keep it for a long period of time. I sometimes, when I remove IUDs that have been there for 10, 12, 15 years, I ask the woman whether she wants to take it home, put it in a little box, because it was part of her body in a way for a long period of time. So I think the IUD serves women by providing very effective contraception in a cost-effective way, and without the anxiety about hormones.
Thank you. And then now for David, it is easy to use the same day concept for IUD in all countries?
Yeah, it's not easy. Why? Because the providers are not trained to do that. You see, in maternity, we have to promote this concept and to train the staff to do that. If not, it doesn't work. And if we see the situation now, I think it's very, very rarely used, this system. But we need that, not only in Europe, in France or in Italy, but in countries like Africa or some country in developing countries, this concept is very, very important because the postpartum, immediate postpartum IUD can avoid pregnancy, repeat pregnancy. We provide that during the time in maternity, just after delivery, to put an IUD. If not, we will see again once a year the woman comes to have baby. Each year. As I saw in Burkina Faso, for instance, in Burkina Faso and Guinea, this concept is used now. The first time I have heard about this concept is in Burkina Faso, because avoid a big number of pregnancy before leaving maternity, you know?
Yes.
Can I,
yes,
Andrea,
yes, please.
Can I just add, I think there are two very important points to make. One is that in many low-income countries, a single visit is probably the only visit that a woman can afford.
Yes, this is very important.
And therefore, it is very important to be geared to do that. To just give you an idea about what happens in the UK, we now essentially the process of offering an IUD to someone is to essentially get them to access a video which tells them about the method. So that's very easy, especially young people are very, very, with TikTok, with the various social media outlets, that is possible. And to run a remote counseling. Remote counseling is, we have people who work within the sexual health service who run telephone clinics. So they ring people and talk to them about the IUD and then book them to come for their fitting, which essentially allows you to do the 2-visit concept with 1 phone call and then a single visit, which is also saves money for the health service, because we're all going into a period of poverty and challenges with the economies.
The problem with IUD access the same day is the following. It's not so easy in private practice. If you want to do the same day, everything, you have to have a lot of model of IUD available in your office. It is possible in certain countries, for instance, in Belgium or in Switzerland, where the doctor gives the IUD, not a pharmacist, like this, he can have a lot of model, and he can use this concept of the same day. If not, it is difficult to use, but it is possible. Difficult, but possible.
Yes, and then just a question for both of you. It is from an anonymous. Hi, and thank you. In your country, when women access hospital for emergency contraception, who insert the device, doctor or midwife?
It is your topic. If not,
it's in French and in England.
It depends of the day where she comes to a hospital. In France, the doctor, it can be the general practitioner, gynecologist, but also midwife, also nurse specialized in family planning. And in UK, you have general practitioners specialized in family planning also, if I know.
And in England?
In the UK, most IUDs are fitted outside the hospitals. So in the hospital, the trick is to train obstetricians to do postpartum insertions. That's the trick. My daughter is a trainee in obstetrics and gynecology in London, and she's at the moment going through her faculty training to learn to put implants and put IUDs immediately postpartum, because that's the need. Most IUDs in the UK are fitted either in primary care and with family physicians, both by doctors and nurses, more actually by nurses, more increasingly by nurses, or they're done in community dedicated clinics, and again, doctors or nurses. Gynecologists will essentially provide IUDs probably in private practice, but not in the National Health Service.
And then a question for David Serfaty. Can we use the same levonorgestrel IUD more than 6 years?
Yes, I can reply yes, because now we will obtain, certainly, not officially what I say, not officially, but I know that we will obtain 8 years official duration of levonorgestrel IUD. But I speak about Mirena or Donacert, not the small one, not Kailina, not Jaides. As I know, officially we will obtain 8 years for Mirena and Donacert, but only in contraception, not in the second indication, it means functional menorrhagia. If we use this system for functional hemorrhagia, always 5 years is official duration. If we use as contraceptive, we can move until 8 years, but we have to wait some days to have official decision.
Yes. Then
David,
yes,
it's only between us. Huh?
David,
Please,
can I also add something about the intrauterine systems? Obviously, some women use the intrauterine hormonal IUD for to manage heavy menstrual bleeding, and many of them will come to me and say, "I'm using this for menorrhagia. It's 5 years or 6 years, and I need to change it." The question to ask is, how are you doing as far as your menorrhagia? And if it is still continuing to manage their menorrhagia, they can keep it as long as it is doing the job. And therefore, if you're using it for a non-contraceptive indication, then that is important. But can I just also say one thing? My apologies, I have to go and do a clinic. So I've got to leave you now. But it was a delight. We must do it again, Andrea and David. We must have another event like this. So thank you very much. And I was really pleased
I am ready to repeat with you another webinar.
Thank you, Ali. We will continue now. We have some more questions for Professor Serfaty. And then the first question, David, is why the immediate postpartum IUD is unfrequently used worldwide?
Yeah, because I told you before, because the gynecologists and nurses are not trained for this technical insertion. We have to learn, and now, thanks to this new inserter, I show you during my talk, this very long inserter with very long string, and you avoid to put your hand in the vagina to put the IUD immediately after delivery. Perhaps thanks to this inserter, and perhaps after this kind of webinar and other meetings, we will continue to promote the immediate postpartum IUD, I think. But for the moment, it's not so frequent.
Yes,
except in certain countries in Africa.
Yes, and then now we have also a question, interesting question that we will need long time to answer, such how do we address misconception on the use of contraception and encourage its use in rural Southeast Asian region where medical support or education is not always available. This is open leave to many comments. And I have a more specific question, is that one, how do we improve the method of insertion of IUD such that it may minimize pain upon insertion?
I think the technique to insert IUD are very known now. Very known. If you use official recommendation, it's really easy to put IUD. We have, in general, we have two systems. Or we use hysterometry before to put IUD. It's classical attitude. Now we can use also one-time insertion without hysterometry. It's also one possibility. And if I can give advice, if you want to put easily one IUD, if it is possible, do that during menstruation. During menstruation or the end of menstruation, the cervix is open, the uterus is not and especially in young people, in nulliparous, young nulliparous, I use this system satisfactory, with satisfaction.
And then a combined question, one from an anonymous, and then some. I want to add something. Is related. Do you recommend to your patients the self-removal of IUDs? And to facilitate the self-removal of IUDs, what should be the length the length of
string.
yes, that we
Yes,
have
yes,
to leave.
So, good question. If you want to promote this system, you have to let string too long. But if you let string too long, it may have inconvenient. For instance, to put out the IUD if you use tampon, vaginal tampon during periods. Well, it's possibility. Or if you use vaginal cup during menstruation, you can not voluntary. You can put out the IUD. Donc, finally, the string have to be not too long and not too short.
And what is not too long and not too short?
Yeah,
how many centimeters?
If they are too short, it can hurt the male partner, I think.
Yes.
If too long, I say it's inconvenient. It's easy to put out involuntary the system. 3 centimeters are good dimension.
3 centimeters.
About self-removal, sure, if they are long, it's more easy. But we have also inconvenience. Perhaps I don't like self-removal as doctor, but if I have to say one word to lady, to woman ask me to do that, I can advise to be in back position. It's more easy perhaps to find the string, and also to say to her boyfriend to put out also the IUD. It's good possibility. The partner, the male partner, can remove the IUD is also one possibility. If not, she has to try again, and finally she will succeed.
Then thank you very much. And then okay, and then I would like now to make a final question just to finish our webinar, is that I would like that you provide us your final comment on the importance and impact of intrauterine contraception today, and how we have to push the company up to study, as you have presented, new advances in intrauterine contraception, taking care of the individual difference of the various women.
Yeah, very good question, because I think the price, something against promotion of this method, because copper IUD are very, very cheap. It's not very expensive. If you are pharmaceutical firm, you think it's not a very profitable method. It's not the same for intrauterine system with levonorgestrel. The price is not obstacle to promote. So we have perhaps to look to encourage firm to continue research in this domain, but we have also to think about rentability of the method.
Thank you very much. Dear friends, I think it was a fantastic opportunity to meet together the European Society of Gynecology and the European Society of Contraception and Reproductive Health societies together under the umbrella of so beautiful masters such as David Serfaty and Ali Kubba. And I thank all of you for being with us. I remind you that this webinar will be on the website of the European Society of Gynecology available, and also on the European Society of Contraception and Reproductive Health. And you then, in that way, you can go back to see again. And for those who registered that were not able to join us today, they can appreciate all the webinar on their website. I thank you very much. And I would like to address to all you all best wishes, and invite you to join the 15th Congress of the European Society of Gynecology, which will be in the beautiful Amsterdam. It will be on site and online, and it will be from 29 November to 2nd of December 2023. Dear friend, thank you of being with us, and many thanks to David and Ali for this beautiful webinar. Thank you. Thank you. Goodbye.
Thank you, Andrea. Thank you, Andrea.